We'll get started here in just a minute. People are still joining, so give us just a few more minutes to allow for a few stragglers, and then we'll get going.
Okay.
Hi, everyone. Welcome to our virtual health series with UCHealth. My name is Danielle Ponton, and I'm an event coordinator with the Highlands Ranch Community Association. We're so excited that you all took the time out of your evening to join us tonight to discuss the very important issue of vascular health. We are thankful to have UCHealth Highlands Ranch Hospital as a community partner and happy to have their representative, Dr. Emily Malgor, here with us tonight. She will be, there will be a Q&A portion at the end of this event. So just keep looking at the chat, or keep your questions coming, and you can add them into the Q&A, which you can see on the bottom. That's different than the chat. So there's a chat and then there's a Q&A button. So add all of your questions into the Q&A so that they can pile up there, and then we can see all of them at the end. And if you have a question, we encourage those, and we hope that you ask those questions. And with that, I will go ahead and send it over to Emily, and she will get us started.
Thank you. I appreciate that. As you all saw, I am Dr. Malgor, one of the easily memorized names. Just joking. It's I'm asked frequently what my name is, but I'm currently the vascular surgeon at Highlands Ranch Hospital. It was opened a couple of years ago, and I've been fortunate enough to get to know a lot of the patients down in this part of Denver. It's been pretty rewarding. Tonight, we're talking about a few topics. There are many, many topics we could go into, and I've selected 3 of the more common things that I see, including peripheral arterial disease, aortic disease, including aneurysms and blockages, as well as varicose vein and other vein diseases. Go ahead and advance. So we're going to start with PAD. This is often described as PAD in patients' charts, and it's a very non-specific way of saying you've got potentially some blockages in your arteries. Typically, when we see the words peripheral arterial disease, we're only talking about flow to the extremities, not the other issues with returning blood to the heart. And here you can see this little picture of a woman grabbing her calf. She's been doing some activity, and now she's cramping up because in this scenario, it's showing that she doesn't have enough blood flow getting down her artery because it's pretty narrowed by plaque. Go ahead and advance. What is PAD? Essentially, it's years and years of buildup of plaque, including hardening of our arteries. This naturally happens as we age. And I'm often asked questions about images of patients' arteries that show calcification or hardening, and that's a natural process that occurs, but it's more pronounced in patients who have contributing factors such as high blood pressure, diabetic disease, smoking disease, sort of lifetime of elevated cholesterol intake, sort of the American diet as we talk about, and anybody that has kidney disease. Those are all contributors to what can be considered hardening of the arteries and plaque buildup. This worsens blood flow, as you can imagine, and we even see patients who have complete 100% arterial blockages, and your body will continue to function for quite some time before it reaches sort of a breaking point, at which time the patients usually present and say, hey, is there anything we can do about this? I'm not able to walk the distances that I used to be able to walk. Next slide. It can affect essentially everything. the patient's hips, thighs, feet, and toes, essentially their legs are the ones I'm asked about most commonly. But the point of this slide is to basically make patients aware that your blood supply, we often talk about vascular surgeons being plumbers because we're essentially operating on your plumbing and trying to preserve flow through all of your arteries and veins. And as you can imagine, if one area of your body has plaque buildup, there's a solid chance, and research shows this and supports it as well, that other areas of your body have plaque buildup. And so sometimes when we see patients with pretty severe peripheral arterial disease in their legs, there is a solid chance that they have plaque buildup in their heart or coronary arteries as well, sometimes in their neck arteries. Next slide. More than 10 million of us as Americans have it. It's very, very common, and it's probably underdiagnosed. But it's most common in patients over 65 years of age, and it can occur at any age. And we presume that the process of plaque buildup begins in our 20s and then occurs over decades. So a lot of the patients we see probably at the top of the bell curve would be patients right around anywhere from 50 to 75 years of age. That's a very common time to present. Next slide. And these are some of the things I mentioned. I left out obesity, but it kind of goes hand in hand with a high cholesterol diet. There are patients in whom they are not obese and they happen to have inherited the unfortunate hypertriglyceridemia or elevated fats and lipids in their bloodstream. Sometimes it runs in the family. I underline smoking because we've consistently proven that it's about 3 times as important a risk factor for peripheral arterial disease as any of the others. And what's special about it too is it's something that can be eliminated. It's controllable, albeit quite difficult to control. Some things are out of our control, if you've got type 1 diabetes or you have renal failure, all kinds of things are more of a sort of medically managed type of process, but we can control our blood sugar. We can control our cholesterol intake and try to diminish cholesterol levels with statin medications. Blood pressure, we do our best to control with activity and with lifestyle changes as well as medications. Smoking is just, as I said, such an important risk factor. It's the first one we try to target as vascular surgeons when we're trying to help people with PAD. Next slide. So do you have it? You might have it, you might not have it, but one of the things that I first tell patients to think about is, have you sort of noticed that you're not as active as you used to be because it's just uncomfortable? Do you have pain when you walk? Are you now no longer able to make it to the end of your block or to the end of your street and you're sort of cramping up in your calves and feet when you get to your mailbox? If you're someone who potentially has pain in your legs when you're not even active and has pain in your legs just while resting, or if you have non-healing sores or scratches in your feet and lower legs, then it's time to start thinking that, perhaps there's a component of peripheral arterial disease that could be treated and help resolve these issues. I think a lot of people don't really realize things until they're bad enough that it sort of hits them in the face. There's a lot of us that walk around with scratches on our feet and ankles. And then you kind of think, all right, that's been there for a solid month and a half. It should have healed by now. Why is it not healing? There are patients who have so much pain in their legs, even at rest, that they actually started sleeping in a chair so that they can hang their legs down to gravity so that it maximizes blood flow to their feet. Because the blood flow is so compromised. So these are questions to think about when you ask yourself if potentially PAD is something to consider. Next slide. And this is where I can help you. And we do get a lot of referrals where we try to hash out if the pain is related to vascular disease or if issues in the extremities are potentially related to maybe lower back issues. Or other illnesses, but vascular surgery encompasses quite a bit, and we can help answer a lot of those questions. And remember that just because you see a surgeon doesn't mean you need surgery. So I often make referrals to surgeons because they are the experts in their specific field. And I try to remind patients that you never have to have surgery unless you choose that it's best for you. And going to a surgeon doesn't mean they're going to say your only option is surgery. So next slide. So here are some things that I like to obtain to differentiate whether a patient has vascular disease, how severe it is, or if they even have it at all. Next slide. I try to start with the least invasive, least expensive, and most convenient studies, which are, we call them non-invasive studies. And one of those is the ankle brachial index. It's a comparison of blood pressure in your arm or brachial artery to the blood pressure in your legs. And these are always performed in the upper arm, sometimes on either side, depending on which arm has the higher blood pressure, and to the blood pressure at the ankle level. There are additional studies I can order that take the blood pressures from the thigh or the upper calf, but specifically these ones tell you, okay, this is the proportion of blood flow in my leg as compared to the blood flow that's reaching my arm, and they should be about a 1-to-1 ratio. Normal is anything from 90% up to 120%. So if the blood pressure in my ankle is 100 millimeters of mercury and the blood pressure in my arm is 110 millimeters of mercury, I'm just under a ratio of 1, and that would be considered normal. And where we start seeing issues with walking tends to be in the ratio of 70 to 90%. We start seeing patients complaining of cramping when they walk, meaning about 70% of your blood pressure in your legs it's about 70% of what it is in your arms. We start seeing patients getting pain at rest, typically when we are below 0.5. So all your legs are only getting 50% of the blood pressure that your arms are getting. Those are the type of patients we start seeing non-healing sores, issues with walking distance. Sometimes no walking at all elicits pain. And oftentimes these patients have significant areas of blockages in their arteries. Next slide. Also non-invasive, performed in the same vascular ultrasound lab, would be an ultrasound. This is imaging. It's frequently confused with a Doppler, and a Doppler is what would have been used on the study I just talked about, where we listen with a little device to hear your pulses with our ears. But this will actually look at the flow in your arteries. It'll tell me if your arteries have blockages or narrowings in them. And the technologist that performs these studies will also take waveforms to see how strong the pulse is at each level in your leg. So they actually look at the heartbeat as it transmits down your leg. And if it's getting weaker as it approaches the ankles, that will be picked up on this very non-invasive study. They usually just use warm gel and a probe, and that's it. No radiation, usually least expensive study. It's often covered by insurance, nearly always. Next slide. If I need more information for a patient, I will often move to the next step. This is more invasive in the sense that these studies require contrast dye, and that's not something we can always use in patients, particularly those who have allergies to it or people who have kidney disease. This dye in CAT scans with contrast and in MRI studies with contrast has to be cleared by your renals, by your kidneys. And so there are some check boxes we have to talk about before we order these studies, but vascular surgeons particularly like CAT scans or CT angiograms, which is where the vessels are enhanced with contrast dye, so they really pop out. And these really accurate pictures tell me a lot about the anatomy and will elicit any areas of narrowing or calcification, complete blockages, and it is essential for surgery planning, particularly if I'm going to be doing something invasive such as a bypass. These are sometimes necessary before I do an over-the-wire procedure as well, but typically I get even better images when I do the procedure over the wire. I take my own pictures. So the A on CT and the A on MR there stands for angiogram, which means pictures of the vessels. Next slide. Like I said, these use contrast dye. They do involve invasiveness in the sense that you get an IV, a peripheral IV, and then the contrast dye is injected through that, as opposed to the ultrasound, which is gentle. It doesn't permeate the skin. The CAT scan involves radiation. I think that's a common misperception, is that MRIs are radiation. They actually have no radiation. They're a magnetic study, and CT scans are radiation. And so we try to limit CT scans as much as possible. especially in young persons, in children, in pregnant women, and in someone who receives a lot of imaging studies, perhaps to surveillance a malignancy or something of that nature. But CT scans are great for me, but not always so great for the patient, so it's not something I can always get. Again, these are great anatomical pictures for me if I'm planning a procedure or a surgery. And all of these can be done at Highlands Ranch, which is nice. Next slide. Angiogram, as I said, is pictures of the vessels. And when we talk about, usually I'll call it a formal angiogram. It's when I'm actually doing a procedure on a patient. Angiograms are performed by radiologists, they're performed by cardiologists, they're performed by nephrologists, vascular surgeons do them a lot. These are essentially minimally invasive procedures wherein most of the procedure is performed over a wire and through a catheter. And the angiogram itself is the pictures, and using the pictures that we take during a procedure, we often will also intervene on the same case. So we use an X-ray machine called a fluoroscopy machine that takes really vivid images, and the amount of radiation can be controlled. And as surgeons, I rarely do an angiogram just for imaging purposes. We almost always go into an angiogram assuming that we will be treating as well. So diagnosing a patient alone is pretty rare. We're almost always doing diagnostic pictures and then also therapy with stents, balloons, catheters, etc. We do these at Highlands Ranch, which is great for me and hopefully really convenient for anybody in this area. Next slide. So the first thing we talk to patients about is their goals. I mean, if you are somebody who hasn't walked in 20 years because for whatever reason, you've got lower extremity weakness, your goals are going to be very different from somebody who was just golfing 2 months ago and now can barely walk one of the greens. So goals are important because they need to be realistic for what we expect to achieve. And it also helps dictate what the surgery or procedure will be in that regard. A patient who is smoking, that's going to be the first thing we try to target. However, if a patient is already experiencing non-healing sores in their lower legs and feet, or if they have pain at rest, we have a little bit more urgency as surgeons to get them under the procedure to improve their arterial flow, particularly if there's tissue loss. We don't really have the luxury of time anymore. The clock is sort of ticking in that sense because any areas of compromised skin can be a nidus for infection. So if somebody is a smoker, the first thing we're going to try to do is get them smoking cessation, particularly if their primary complaint is, I have cramping with walking, but I'm still able to go a certain distance. We'll say, perfect. You don't need a surgery yet, but we really got to get you on the right medications and get you to stop smoking. And the rest you can see here. If somebody is particularly prone to foot injury with diabetic disease, where you tend to lose your sense of touch from peripheral neuropathy, we really try to capitalize on the proper footwear and wound care. If somebody does have wounds, we do all of the studies I just spoke about to make sure that they have enough blood flow down to the area of the wound that will allow for it to have a good chance of healing. And if not, that's where we start to get involved. Clot busting therapy tends to be what people think of when they hear of somebody having a stroke and they rush to the hospital, and clot busting medication is used to break up a clot that's traveled to the brain. And similarly, there are patients in whom we do this for clots that have traveled to the lung or clots that have gone to other arteries in the body, particularly the legs. Ideally for the patient, we can do things over a wire endovascularly. And most people think of that as balloons and stents. And sometimes there are other little devices we use. Bypass is often a good option for patients who don't have good minimally invasive options, sometimes based on their anatomy and sometimes just based on our inability to cross a blockage. Amputation is the last resort. It's a good option for some patients, and it's certainly not something we take lightly or look to do. And I think if you're ever told you need an amputation, it's always a good idea to get a second opinion, because there's potentially people who can salvage the limb. You'll have different levels of aggression in terms of surgeons' approach to salvaging a limb. So I always said, if we're ever going to amputate anybody's lower leg or foot or toes, you always have to have pictures. So the surgeon needs to make sure they have really good images. all other options have been exhausted, and then I encourage the patient to usually have 2 people look at them. Next slide. So this is the second topic I wanted to talk about, and it's sort of an extension of the first in the sense that blockages can occur above the groin, in the pelvis, and in the area of the abdomen. The picture here is a little misleading. It's just showing you a plaque again. But the idea in this segment of the talk is that these same plaques can affect much larger arteries, and the ones above the groin are about 1.5 times in size those of the legs. So as you move further and further from the heart, as you can imagine, the arteries grow smaller and smaller, like the branches of a tree. And the aorta is the largest artery in your body. It comes right off the heart and immediately starts giving off branches. The first ones it gives off are your arteries to your heart, and then the large, super important arteries to your arms and neck and face and brain. And as it moves through your chest and enters the abdomen right after passing through the diaphragm, it starts branching into the arteries that supply your intestines, kidneys, stomach, liver, all of that. And right at the belly button, it forks into 2 and heads to each leg. And so aortoiliac occlusive disease, when we see AIOD, it's almost always referring to plaque and blockages that are affecting the aorta in the lower abdomen as it's branching into the legs. It's a very common area to be blocked. It's the second most common in the body. And as you can imagine, it's a big artery. A lot of plaque can build up there. And it's very hard on patients because any of the cramping and pain that I already talked about, the patients feel from basically the hips down. In gentlemen, it can cause erectile dysfunction. We tend to pick up on it from both the patient's history as well as an absence of an ability to feel pulses at the level of the groin. Those pulses should be nice and strong, really easy to feel. And when we don't feel those, the first thing we think of is aortoiliac occlusive disease. Much more common in smokers. There are people walking around who have a completely blocked aorta and they are okay, but it tends to give a very limited walking distance. And again, complete blockages here tend to transmit into pain down the legs. Sometimes the blockage is limited just to the aorta and everything below it is pristine. And if we can just get that area treated, the patients can have complete recovery of buttock pain, erectile dysfunction, pain in their hips, pain in their legs, limited walking distance, everything. So this is a pretty critical area, and we call it the inflow. It's basically all of the flow to your legs is coming from here. And if you correct blockages, you should always start at the highest point and then work your way down. So this would be the highest point. Next slide. A lot of people have it. More than 10 million of us have it. And again, similar to PAD, it occurs in middle age. I don't even know if we can call that middle age anymore. People are living into their hundreds nowadays, but 65 for us almost seems young now. We get patients in their 90s on a regular basis. And for patients over 65, it is something we see more often. As I said, plaque tends to start occurring, we think, in the 20s, people's 20s, when we're young and healthy and we don't feel really any disease. It sort of builds up over the years. Occurs in about 1/5 of people over the age of 65. Next slide. Same risk factors, same process. And as I said, that one slide that talks about how vascular surgery is dealing with our plumbing. If one area of your pipes with your blood flow is blocked, there's a good chance there's another area blocked as well. And so this is the exact same process, just in a larger vessel. Next slide. Same things people complain of, but the ones that we highlight are at the bottom because the blockage is usually 1 degree higher than the area of your issue. So for instance, if you've got a blockage in the artery of your thigh, you're going to feel cramping in your calf, potentially in your feet as well. If you have hip and buttock pain and you have this deep, deep ache in your pelvis, and if a gentleman is experiencing erectile dysfunction and has for some time, the level of blockage is 1 degree higher. So then again, we think about aortoiliac occlusive disease being above the level of the groin and pelvis and more up in the upper abdomen. So the blockage is always 1 degree higher than the issue. Next slide. And we can definitely help. This is, I'm finding there's a lot of different types of providers that assist with arterial blockages, and this is certainly our specialty. This is what we do. We trained for this. There's a lot of principles that go into how you approach blockages, how you help patients. The number one thing usually being their history and their goals, dictating what you're going to do. But yeah, please think about vascular surgery if you have any of the things that I've already mentioned, because we can even just have a discussion. And again, just because you talk to a surgeon doesn't mean you need surgery. Next slide. We start with the same minimally invasive tests, non-invasive vascular lab. ABI is the one that compares the blood pressure of the arm to the ankle. The ultrasound is the images, the first most easily obtained images. They have a little bit more limited role because, as you can imagine, it's a lot more difficult to see your arteries with an ultrasound probe once they've dipped into your pelvis. There's a lot more tissue there. The gas inside of our intestines obstructs the view that you can get with an ultrasound, and oftentimes they'll have patients completely go without eating breakfast and lunch before they have an ultrasound of the belly because you almost can't see anything. The heavier a patient is around their midsection, if you struggle with abdominal obesity, it's going to be a lot more difficult to get much out of the study. But even in slender patients, we find that it's oftentimes best to just use a CAT scan or an MRI. Whenever I meet a patient who doesn't have pulses that I can feel with my fingers in their groins, my first thought is CAT scan, because ultrasound is most beneficial, I think, on the extremities. Once we enter your torso and your belly and your pelvis, it's usually best to just get a study that's going to show the anatomy better. Next slide. Angiogram, again, is pictures of vessels. And when I talk about angiogram specifically, I'm usually referring to a formal angiogram, which is an invasive procedure using a needle, a wire, and catheters. Again, we use contrast dye. The one nice thing about this is if you image a patient with an angiogram, I can control how much contrast I use and I can dilute it. I routinely dilute it 50 to 50 with saline. Whereas if you get a CAT scan as your first imaging study, as opposed to a surgeon performing pictures themselves with a needle and a catheter, you will get full strength contrast, usually on the order of 100 to 120 milliliters. So it's a lot. It's a big push of contrast dye. It goes right into your vein, gives really beautiful pictures, and then your kidneys have to clear all of it, which is why we say drink, 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 drink a lot of water when the study is over. If I'm doing the study myself in an angiogram, I'll usually dilute it 50% with saline, and I can get most of the information I need without using really dark pictures. Once I have the images I need, that dictates everything. Next slide. Endovascular treatment, much of it is balloons and catheters. As you can imagine, the balloons we have nowadays are extremely fancy. We've got balloons that are coated with medication that's supposed to inhibit plaque advancement. We have balloons that have little wire cages on them that are supposed to cut into the plaque as they expand and break it up, make it easier to rupture the plaque. We have all kinds of devices. Sometimes there's a device called an atherectomy device, which is basically like a little Pac-Man chewing the plaque out of your artery to create a channel, which we then treat with a balloon and break it open. Once you get an artery opened, we frequently utilize stents to maintain that wide open artery and prevent it from narrowing back down. It can still do that, which is why once a patient gets a treatment involving a stent or even a little Pac-Man atherectomy type of treatment, we will watch you pretty closely, usually re-imaging you with an ultrasound picture at 1 month, 3 months, 6 and 12 months. When we do these traumatic treatments to the inside of a vessel, we also will usually have you on a couple of blood thinners. It's not uncommon to be on aspirin forever if you meet me. I'll usually prescribe aspirin like a vitamin. And then I typically will have patients who received a stent have at least 3 months of Plavix, which is a heavier version of aspirin. There are often patients on blood thinners for atrial fibrillation. So they do get nervous, and we have to take that into account when patients are on 1, 2, 3 blood thinners. Certainly your risk of bleeding is increased. As a vascular surgeon, we tend to shy away from minimizing blood thinners. We tend to push patients into multiple agents if we think it's going to protect your arteries. We are not the ones to hold blood thinners typically when we operate. We often operate while a patient's on 2 blood thinners because we need that blood to keep moving. Clotting is the enemy in our case. So next slide. Treatment options, we talked about minimally invasive a moment ago, and then obviously bypassing is a surgery. It's a big open incision, but it's often still the gold standard. And it hasn't changed a lot since the 1950s. We still use a lot of the same fabrics in bypass material that we used long ago because it has withstood the test of time. These are typically a one and done type of thing. If you get a bypass and you make it successfully through the first year of that bypass and everything is without issue, you're usually good to go for life. These are meant to last forever. Certainly we see weakening where the suture lines are, where we've sewn this fabric into the artery itself. But sometimes we are limited in our capabilities to cross blockages with wires and catheters. And sometimes it's the only thing you can do is get in there, clamp the vessel, open it, and sew a detour bypass right across the blockage and restore flow. And this restoration of inflow, as I called it, is basically like getting a new artery put in. And as you can imagine, in this picture, there's that huge yellowish orange plaque right in the middle of the patient's body. The bypass jumps right over it. And sometimes it's like opening the dam of flow to your legs, and patients will have a significant change in their symptoms within, hours of surgery. Oftentimes it's very satisfying for both the patient and the surgeon. There are obviously complications that occur with these. These are much more invasive. They require a lot of patient optimization before surgery. But again, bypass is sometimes the best and only way to treat blockages. An aortic bypass, An aortic bypass is what you see here, where we jump straight from that big artery, the aorta, down to the groins. And that we call an aortobifemoral or bigroin bypass. An axillary bypass, sometimes patients are not able to have their abdomen opened. It's a very invasive, stressful procedure to the body. And in the sickest of patients, or in patients who simply cannot have fabric or a foreign material inside their abdomen, we will sometimes take a bypass right from the artery under your collarbone and track it along the side of your body and take it down to the groins that way. Those are obviously harder to maintain because it's this big, long plastic or fabric tube, and your blood flow's got to be basically without any issue so that you don't develop a clot along this man-made artery. But there are reasons to do both, and we do these frequently. So next slide. The other type of disease that affects this part of your body and other parts as well, but I specifically focused on aortic aneurysms, is aneurysmal disease. Very different from what we've been talking about, which is blockages. We frequently see patients with aneurysms who have 0 peripheral arterial disease and no aortoiliac occlusive disease. They are plaque-free, but unfortunately have inherited an aneurysm. And thank goodness we find these nowadays, because they are a silent disease and you often don't know about them until they are fatal. And aortic aneurysms are something you want to know that you have, because the patients that don't know that they have them and who rupture or burst, because that's what these do, 50% never make it to the hospital, and about 50% of those that do never make it off of the operating room table. These are things you want to prevent and catch before they rupture. Next slide. It is a weakening of the wall of the artery that causes it to balloon out and dilate. And it occurs most in the abdomen, but we see these a lot of times in the chest and in the legs as well. One of the important things I tell our team is that whenever you find out somebody has an aneurysm in their belly, it's also good to check behind their knees, because a frequent place for aneurysms to occur is right behind the knee in the popliteal artery. This is a concern for a rupture in the chest and the belly. Once you get below the groins, for some reason, our bodies tend to not develop aneurysms that rupture, but rather they collect debris inside of them, and the debris can be showered down into the legs. So when we see an aneurysm below the groin, we tend to worry more about somebody getting a blockage. Whereas anything in the belly, we are definitely trying to prevent it from rupturing. Next slide. Less than 10 million, so much smaller number, thankfully, but still a significant number of Americans every year are diagnosed with an aneurysm. Thankfully, a lot of the ones I see are small. We don't treat these until they are greater than 5.5 centimeters in men and greater than 5 centimeters in women. They're much more common in men, and actually, the FDA has approved screening ultrasounds of the belly in patients who are male and have either a history of smoking more than 100 cigarettes or who have a family history of aneurysmal disease. It used to be that females were cleared for approved screening as well if they had both of those things, and I believe that has changed recently. It's probably something that you would have to pay for if you had a suspicion that you might have one. But smoking, as you can imagine, is a significant risk factor for degeneration of the arterial wall. And so sometimes when patients have no other risk factors, no family history, but they say, yeah, I smoked for about 10 years, we sort of chalk it up to that because we don't know what else could have potentially caused it other than just them being the first one in their family to have it. Next slide. Questions to ask yourself. If you feel a pretty strong pulse in your belly, if you're laying flat in bed on your back and you feel your belly and you feel a little kick with each heartbeat, it could just be that you have a really strong pulse. I can feel my pulse in my belly if I lay flat on my back, but you know, in some patients, it may be concerning for an aneurysm, particularly if you feel a fullness there. Some aneurysms are too small to feel, but it's something to consider if you have risk factors for potentially having one. Check behind your knees. Is there any real fullness back there? Any really, really strong pulse behind your knee? Because behind the knee is often a hard pulse to feel. When it's really prominent, we tend to start imaging the legs just to make sure we don't miss something. Do you have a history of blockages that occurred out of nowhere in your legs that may have even taken you to the operating room emergently? We look for a source. And one of the first sources I think of when a patient has a blockage in one area of their body is an aneurysm. We start hunting for an aneurysm if somebody has an embolic event like that. If you have any sudden chest, back, or abdominal pain that is horrific, just persistent, constant, nothing you've ever felt before, go to the ER. Number one, it could just be indigestion, but we've found plenty of patients who present to the ER didn't know they had an aneurysm and it has burst. And there's a lot that we can do, even if it's already ruptured. We can save patients who have already ruptured. So always get yourself to an ER. It's okay to get checked and find nothing. I mean, who doesn't love that kind of news? So next slide. We can help. Give us a call. And if your emergency department is not sure what to do with you, just say, you know, if you know us by name, just ask for vascular surgery if you have a specific concern. Certainly, we're happy to be called. And it's a lot easier to catch me at Highlands Ranch than potentially catch my partners sometimes up at Anschutz. But anywhere and everywhere we are, people are happy to help, and we'd rather be called than find out later. Next slide. We start with an ultrasound unless we suspect something emergent, and we'll go straight to the CAT scanner if your vital signs can handle it. Some patients come in and they are already unstable from a hemodynamic standpoint, but we want to get good imaging. If you're just being screened for an abdominal aortic aneurysm, you'll definitely get an ultrasound first, and it will look just like that picture where you see this nice smooth artery on the left of the picture, and then basically what looks like a little belly, almost like the belly of a pregnant woman. And that's the artery ballooning out forward towards the front of the belly. And a CAT scan is going to give us beautiful pictures. Those are almost necessary if we're going to do any form of endovascular repair, which is now the gold standard. Most patients are fixed minimally invasively nowadays. Rarely do we do the big open surgical repairs. Even in complicated aneurysms that involve major branches. Next slide. This is what an endovascular aortic aneurysm stent graft looks like. It looks like a pair of pants. We put in a cage lined with fabric, and there are many different brands that we use. It goes in through a puncture in your artery of your groin, and we usually use both groins. One groin is used to put up almost the entire pair of pants, and the other groin is used to extend the pant leg on the other side. So It's not a device that goes through a tiny hole. The hole is pretty big. It's about the size of a pencil. But in the scheme of things, it sure beats having, you know, a foot-long incision on your belly that takes 4 days to get you out of the hospital and involves a lot of pain. Both are good options. This is the option we like to do in patients. It has better outcomes. It does require contrast, but there's a lot we can do if we're limited in the amount of contrast dye we can use. Small device is inserted, and once we position it where we want it, we essentially unsheath it and it springs open. So these are often held in place only by radial force alone, and the whole point is to achieve a seal zone, a watertight seal zone at the top of the graft and at the two bottoms of the graft. So anywhere you see the end of a graft, we want it to be snug against the inside of the wall of the artery, so no blood flow can move outside of the graft, but is forced to flow right through the graft that we put in. What that does is it doesn't take the aneurysm out of your body, but it takes the flow out of the aneurysm. And as such, that depressurizes it. And once you've taken the pressure out of an aneurysm sac, your risk of rupture is gone. So the aneurysm is not physically removed as it would be in an open surgery, but it is depressurized. That's the goal of these, is to essentially eliminate flow through those large balloon-like sacs. And then our hope is that they clot and start to shrink as they scar. And when you see that an aneurysm has shrunk since surgery, then you know it's fixed. And we often get people out of the hospital in 1 day nowadays. It's pretty awesome. Next slide. Open surgical repair is awesome, but not so much for the patient. It's still a great option for people whose anatomy just does not support doing it over a wire. There's a lot of restrictions we have as surgeons. Sometimes the access vessels through your pelvis are too small. Sometimes they're too calcified. They can be really twisty, and it's dangerous to introduce one of these big pencil-sized devices through tiny calcified arteries. The biggest issue with open surgery is we have to make sure the patient's body can handle a complete disruption of blood flow. And if you see in that cartoon there, you can see the surgical clamps across the vessel. To work in a dry field where there's not constant bleeding, we have to fully cross clamp the artery before opening it. And as you can imagine, that stresses the heart a lot. So these patients will often undergo extensive testing to make sure that their lungs and their heart are fit enough to handle the stress of this kind of surgery. But once it's fixed, it is fixed. We sew in the graft, and usually those two little yellow flaps you see on the side are the aneurysm filleted open, and we'll often wrap the new graft in the old aneurysm sac to protect it from infection. These are usually a longer hospital stay, but even still 4 days, sometimes 3, huge improvement from a long time ago. It was minimal hospital stay of 10 days in the past. So we try to tell patients the recovery is several months. For several months, you will feel like the wind has been taken out of your sails. And actually, that's true for the minimally invasive version as well. Patients think, I don't even have an incision. Why am I so worn out? But if you think about it, your body is trying to incorporate this foreign material. It just wipes out your immune system while your body's sort of primed and trying to figure out what this new foreign body is. So your immune system is very active in this recovery from surgery, whether it's this type of surgery or the one we just spoke about. And you can expect to not feel like yourself right after. Next slide. All right, so I need to move faster so you guys have time to talk and ask questions. I have an entire topic to talk about, and I'm going to talk faster, so I apologize. I see a lot of vein stasis disease in my clinic, and it's something that can be really mild in the form of spider and varicose veins, or it can be patients presenting with really bad swelling, ulcers, or just some hyperpigmentation, kind of like you see on the patient's legs on the left of the screen here. Next slide. This is when your veins in your legs, which are the vessels that return blood to your heart, they're not the ones putting blood into your extremities. These veins all have little one-way valves in them every few centimeters. And when these valves are working properly, they are watertight. So they should only allow blood to go towards your heart. But if these vein valves are leaky, then blood is still flowing towards your heart, but a significant portion of it is pooling back down in the vein segment that is affected, and it pressurizes your veins. So over the course of the day, you can imagine blood pools in your legs, causes pressure, and it can cause pain, restless legs, varicose veins, swelling, color changes, skin changes. So this vein reflux or venous insufficiency is called venous stasis disease or chronic venous insufficiency. Sometimes it's asymptomatic, and it may be unsightly, but a lot of times there are symptoms associated with it. Next slide. Tons of people have it, and we think it occurs more often than we realize. It's suspected that 40% of people in the US have it. That's a lot of people. The causes we know are, again, smoking. So if you're a smoker, definitely talk to me or find a physician or provider that can help you think about a quit date or setting goals for quitting. Smoking is sort of the opposite of everything we try to achieve in vascular surgery. It's just so hard on patients' bodies. Lack of exercise causes stagnation in your blood flow of your vessels, and that is a contributor to pressure in your veins. Obesity is one of those things as well. But if you've ever had a blood clot, also known as a DVT, in your deeper veins of your body, that makes you more susceptible to this type of vein stasis disease. And phlebitis is inflammation of your blood veins. So if you have had a clot in one of your varicose veins and it's inflamed and tender, that's phlebitis. These are the risk factors you see below. Some things are controllable, some are not. Next slide. Do you have any of these things? If so, you may and very well likely do have venous stasis disease. When we see ulcers or sores, again, we talked about arterial disease. We have to, as vascular surgeons, figure out if it's related to something going on with the patient's arteries or their veins, which is fairly easily done. But again, cramping, restless legs, this deep ache in your legs that you experience every night at the end of a long day of work, swelling that's just been there for years, you don't really know where it came from, things like that. This may very well be due to vein disease. Next slide. Next slide. Again, we start with pictures. This is really the only way to figure out if you have reflux in your veins, if the valves are affecting flow in your veins, and it tells me what I can do to help you. A lot of the treatment is non-surgical, but there are certainly procedures that we can do that are a pretty quick fix for this type of thing. Next slide. The first thing we will get everyone to do is wear compression stockings, and those are those really pretty socks your family members wear. We all think about our parents wearing them, but they are something I think almost everyone would benefit from. All of us are on our feet, whether it's standing, walking, running throughout the day. Anytime your legs are down to gravity, your body has to fight gravity, and it does that very effectively. But when that system breaks down, that's when we use compression stockings to compress the most superficial veins and drive that pressure and that fluid into the deeper part of the leg to direct it upwards towards the heart. There are different ways to prescribe these, and these take out swelling, number one, and they will eliminate many of the symptoms patients come in with. Next slide. We try to get patients to be physically active. Obesity is prominent, and there's not an easy fix to obesity. We don't say, hey, go lose some weight, we'll help you someday when you lose weight. That's not the way we approach this. It's not appropriate. We do try to encourage patients, however, to be active, because if you're going to find recovery from venous stasis disease, losing weight and being active is one of the best things you can do, because it takes pressure off the veins. And oftentimes, if we were to perform a vein surgery in a person who had venous reflux disease, it will frequently fail. They won't get optimal results if they are heavily overweight. That's oftentimes why we tell pregnant women, wait until you're done having children if you want to get your veins treated, because they frequently recur when a woman is pregnant. Next slide. Treatment options, starting with the least invasive. This is sclerotherapy. It's what a lot of people talk about. These are injecting the tiny veins under the skin using a tiny, tiny needle, the kind of needle people use for insulin injections and TB shots. We use a chemical and make a foam out of it and inject it right into spider veins, right into those blue veins in your legs, and sometimes into varicose veins as well. They are not frequently treated completely with one treatment. We've had a few patients, though, that don't need to come back. We do one treatment and they're just gone. We do these out in the clinic, and you don't really need much in the way of anesthesia. We typically use numbing cream, and sometimes we'll give patients a Xanax or a Valium. Next slide. Phlebectomies refers to removing varicose veins surgically. These are tiny little incisions that I make. I can do them in the clinic as well. I do a lot of them in the operating room if I'm combining them with another procedure, or if they're really extensive. But these are tiny, tiny 2 to 3 millimeter incisions. We numb the leg, hook the vein below the skin with a little tiny vein hook and disrupt it. And sometimes I will tie the separated ends of the vein with a tiny little suture. But oftentimes, if you just disrupt flow through the veins, they will shrivel up and disappear. And that's our goal. Next slide. This is a procedure reserved for the veins in the leg that travel nearly the full length of the leg. It's called the saphenous vein. There's a great and a small saphenous vein. These are frequently the underlying culprit of most varicose veins and venous disease, and they are treatable. The great saphenous vein runs from your groin to your ankle on the inside of your leg, and your small saphenous runs from the back of your knee to your Achilles tendon on the back of your calf. When we find that these have significant reflux or leaky valves, we can thread a wire up through the vein, pass a catheter over it, and literally heat the vein closed. So that is a thermal type of treatment, and that's what you're seeing in this picture. There's a non-thermal treatment option as well, where we can use foam, the same type of chemical we used to treat the veins in the former slide, the spider veins. We can use those in these veins as well. Venous Seal is a type of medical glue only available to people with Medicare, TRICARE, and Federal Blue Cross Blue Shield. So we don't get to use Venous Seal as much, but it's an awesome treatment because it's essentially painless. And you use a medical glue to close the vein. The entire purpose of these treatments is to stop flow through the veins, either by disrupting them or heating them shut, so that once you've eliminated flow through them, they lose their inflammation and many of the symptoms disappear as well. Next slide. Phlebectomies, oops, we talked about that one, sorry. Maybe I have 2 of those slides in there. This almost never happens anymore. Vein stripping is kind of what, almost of historical significance only. There are occasionally patients in whom we have to physically remove the vein from their body. This causes more swelling, more bruising, it's more painful, and it is nearly a thing of the past, thankfully. Now the procedures are much less morbid and patients recover a lot quicker and usually require no narcotics. I do these procedures and the recovery involves ice packs and usually over-the-counter ibuprofen, Motrin, Tylenol. Next slide. So I just wanted to throw this slide in. I know we only have about 7 minutes left in my hour-long allotted time, and I welcome you guys to ask me as many questions as you can. I'm certainly welcome. You're welcome to my time for as long as you need. Vascular surgeons do a lot of different things. We touched upon the ones in red. I highlighted wound care because I recently started treating patients with open wounds, essentially anywhere on the body. We see those patients as well at Highlands Ranch now. But vascular surgeons also perform neck artery or carotid stents. We perform open carotid surgery to clean plaque out of these arteries. We take out tumors in the neck. We work on arteries of the kidneys, arteries of the intestines when they have blockages or aneurysms. I place dialysis fistulas. I place dialysis grafts. I do fistulograms to keep those things open. I treat lymphedema. And I treat thoracic outlet syndrome, which is a syndrome patients experience when they have a really tight space between their collarbone and their first rib that causes symptoms in the upper extremities. We see a lot of those typically in patients under age 20, from about teenage years to age 40. It's very common. Spine exposure I threw in there. We expose for large orthopedic spine procedures. So the point being, there are a lot of things on here you might not have been aware of that we do. Even my parents don't know what I do, if that sounds familiar. But vascular truly is meant to treat any and all vessels. And I think the only 2 territories that are really off limits to me and other vascular surgeons are the heart, which is treated by cardiothoracic surgeons, and the brain. And neurosurgery and neurointerventional radiology treat those. But everything else is fair game. And we just education is a big part of what we do. Next slide. So if you are watching this, you might be like, seriously, you guys do all that? So yes, this is a question that comes up a lot. What do vascular surgeons do? What is that? That happens a lot in the hospital. There's a lot of other services in the hospital that are still kind of learning what's out there and what's available to patients. And these kind of talks, I think, are critical just to sort of get the word out that you have all of these options available to you at Highlands Ranch. I provide them if I feel like you're a patient that needs a little more TLC and closer monitoring. Sometimes I do the surgeries up at Anschutz just so we have more resources available to us, but that's rare. The big thing is that Highlands Ranch has a lot of capabilities, and hopefully it's a very much more convenient place for anybody that lives in this area. Next slide. If you guys have questions, definitely contact me, and I think our host is going to be submitting my information to your email addresses if you provided them. But if you want to write these numbers down, the big one is my extension at Highlands Ranch Hospital. If you ever get into the operator at that hospital and want to just ask for vascular surgery, they'll connect you. I'm pretty easy to find. As you can imagine, there are almost no people in the world with the last name Malgor. My husband happens to be a vascular surgeon as well, and he works at Anschutz. So if you ask for Dr. Malgor, make sure you specify the female Malgor. If you're looking to be at Highlands Ranch, and if you want my husband, he would be happy to see you as well. The big one too is this bottom website is actually our Society for Vascular Surgery's website. It has a lot of info on there for providers, but a lot of patient information, particularly with regard to the 3 diagnoses we talked about. And that's all I've got. I cannot wait to hear your questions.
So we have one question right now that is coming from Maria. She's asking if can prolonged standing in one place cause venous stasis disease?
Yes, that is one of the causes. And, you know, as you can imagine, we're all standing. And if we're not standing, we're moving and then standing. It's just a part of life. We're either standing or our legs are hanging down off the edge of a chair. That's just the natural process of things, which is why I think this is probably an underdiagnosed thing. As I said, it's prominent in 40% of the US population, and it's probably a lot higher. I think there's a lot of people walking around with achy legs and they don't really know why they have it. But one of the ways we combat that is just trying to increase our activity. Every time you take a step or exercise, your calf muscles are actively responsible for pumping blood flow up to your heart and fighting gravity. When that system is not adequate enough, compression stockings play a huge role. They essentially squeeze your leg tight enough to push the blood flow into your deeper veins and to squeeze fluid out of your skin, and it really helps with recovery. All right. I see a question here. I currently have a small non-deep system, but I have a small superficial blood clot in my left calf. Is it from spinal surgery? Currently, both of my feet down to my toes swell, worse in the evenings and overnight. Could it be from the clot or something else? Typically, if you have swelling, spine surgery, the first thing we look for is a DVT. Thankfully, you did that. That's a really important thing to do. I tend to see fewer leg swelling episodes from orthopedic surgeries that don't involve the knees. When people have had knee replacements, we see a lot of leg swelling or ankle surgery. Spine surgery is tricky because you really do have to decide, okay, did it disrupt some of my lymphatics? Is there more vein pressure up above? I think the biggest thing with spine surgery, so my answer in some ways to that is no. The swelling, the little blood clot, it's hard to say. Certainly without a DVT, there shouldn't be any reason for you to have higher pressure in the veins of your lower extremities. But the thing with spine surgery is it causes you to be immobilized. Spine surgery is one of the highest risk factors for a deep vein thrombus or deep vein blood clot, a DVT. And that's because of immobility. Patients are often bedridden for a while in recovery, or they have a difficult time just learning sort of to walk again when they've had spine surgery. So it's like there's a risk factor there, but you've already ruled out the big one, which is a DVT. It's not unheard of, though, to get blood clots in your superficial veins when you've undergone general anesthesia, because just anesthesia itself is a risk factor for clotting. Your whole body is sort of in this pro-inflammatory stress state, and your blood is more prone to clotting when you're stressed. I hope I'm doing these in the right order. It looks like I am. In terms of a familial connection for aortic screening, how close does the relationship need to be? Doesn't need to be close. It could be an uncle or a cousin. Typically, the closer in relation it is to you, the higher likelihood of it being transmitted. Parents and siblings for sure. And then grandparents, anything in that axial, like grandparents to parents to children, that's going to have a higher, closer association, but uncles and aunts are not off limits either. And certainly if there's a smoking history there, it's something to consider for sure. These are easy questions. I love it though. You guys are welcome to ask any and all. And if you have questions about your own personal health that have come up, feel free to ask. But it's been great talking to you. I know I took a long time.
Well, if that's all the questions we have, then I will go ahead and close us out. Thank you again so much to UC Health and to Dr. Malgor. We really appreciate you being here tonight. And oh, sorry, it looks like we have another question. Sorry, I just saw one come through. If you want to answer that real quick.
The soles of my feet swell at night and are sore. Do you know if, think about if the swelling maybe is occurring earlier in the evening? Is it something you're kind of slowly noticing building up over the course of the day? And yes, it could be venous stasis. And we use the word disease, but disease always has those heavy connotations of badness. Venous stasis disease is one of those nice things that you have the luxury to think about. It's not usually an emergency and it's not life-threatening. It's typically never limb-threatening either. But it can be as simple as swelling that's only noticed in the pads of your feet. And sometimes patients will have really nonspecific symptoms, one of them being, hey, doctor, I feel like when I walk around, I feel like I don't feel the ground as well as I used to. It's almost dull to the touch. And that can just be from swelling, which certainly can be from this process, yes. And if you guys want me to type any of these, I suppose I could so that people can see them. But
and we'll make sure that all that information and the slides get sent out to everybody as well. So that way they can kind of go back through and look if they have questions back at slides and stuff like that. So thank you again for being here. We really appreciate your time. For those of you who are interested, we have another talk with UC Health coming up on April 7th at 6 p.m. again. And this one will be on your head and your neck. So some great information for that as well. And you can find more information on that talk at hrcaonline.org/yourhealth. Thanks for joining us. And thank you again, Emily. We really appreciate your time.
Thank you, everybody, for your time as well. Appreciate it.